Hi everybody, welcome again to Dr. Manny's YouTube Learn Shops. In this presentation we'll provide an overview of thyrotoxicosis, diabetes insipidus, syndrome of inappropriate ADH and diabetic ketoacidosis. Remembering that thyrotoxicosis results in an enlarged thyroid gland, which is typically referred to as a goiter. Now, hypothyroidism occurs essentially when the thyroid gland produces too much of the hormone thyroxine, T4. And it's often associated with an autoimmune disorder, the most common cause, called Graves' disease, or by a metabolically active thyroid nodule that's making too much of the hormone. Now, there are numerous disorders, as mentioned, that result in hypothyroidism, but Graves' disease is the most common cause. And basically, hypothyroidism accelerates the body's metabolism, which can cause tachycardia, hypertension, unintentional weight loss, heat intolerance, and many, many more, which we'll discuss. What's the etiology? Well, the most common etiology, cause, pathophysiology, relates to Graves' disease, which is an autoimmune disorder in which the antibodies stimulate the thyroid gland to produce excessive amounts of thyroxine. There are other associated disorders which are more rare, like Plummer's disease and thyroiditis. What are some of the clinical manifestations of hypothyroidism? Well, tachycardia, hypertension, unintentional weight loss, increased appetite, palpitations, anxiety, fine tremor, heat intolerance, sweating, diarrhea, a goiter, difficulty sleeping, and sometimes even in relation to cardiac issues, you can develop a dysrhythmia, atrial fibrillation. What are some of the complications associated with hypothyroidism? Well, cardiac problems. I mean, you can go into heart failure. You can develop atrial fibrillation, which also decreases cardiac output and increases your risk of having a stroke. Osteoporosis, because again, the thyroid hormones T3 and T4 interfere with calcium absorption or reabsorption. You can have eye problems, such as Graves' ophthalmopathy, which results in bulging, red, swollen eyes. It can also result in photosensitivity, photophobia, sensitivity to light, blurred or double vision, and if untreated, this can actually result in blindness. You can also develop a skin disorder called Graves' dermopathy, which causes skin redness and swelling. In a life-threatening situation, you can develop what is called a thyroxic or thyrotoxic crisis or thyroid storm. And this is life-threatening. And some of the manifestations could be a fever, sweating, vomiting, diarrhea, delirium, severe weakness, seizures, the irregular pulse and palpitations, jaundice, hypotension, and coma. How do you diagnose it? What are your assessment tools? Again, as always mentioned, medical history or history and physical examination are important. So therefore you've got inspection, palpation, auscultation. Okay, on inspection you may see the thyroid gland is enlarged, it may be tender, when you're doing palpation, the pulse rate may be rapid and irregular. Blood tests can include T4 levels or thyroid stimulating hormone levels, which are both indicated of an overactive thyroid gland. You can have certain tests like your radioiodine uptake test, where oral radioactive iodine collects in the thyroid gland, and this can now confirm hypothyroidism. A thyroid scan, same again, radioactive iodine uptake is reviewed. Other tests that can be done can be a thyroid ultrasound, CT scan, MRI, What's the medical management for hypothyroidism? Well, it can be radioactive iodine, which can destroy part of the gland, but it's not an exact science, so sometimes too much of the gland may be destroyed, and as a consequence of that, the person may require thyroxine supplements for the rest of their life because they're hypothyroid. Or antithyroid medications can be taken which prevent the thyroid gland from producing too much T3 or T4. Beta blockers are probably going to be palliative to control things like the rapid heart rate and palpitations. Or a surgical intervention could be a thyroidectomy. And typically this is done when antithyroid medications or radioactive iodine therapy is contraindicated. However, it may not be an exact science as well, and too much of the gland may be surgically removed and the patient could become hypothyroid and again require thyroxine supplements for the rest of their life. However, there are added risks by having the surgical intervention: damage to the vocal cords, removal of the parathyroid glands, and this again may require lifelong treatment with synthetic thyroid hormone, T3. Now let's look at diabetes insipidus. And this is a clear distinction from diabetes mellitus. Insipidus comes from the Greek, which basically means bland or non-sweet urine. By definition, diabetes insipidus is a condition that causes an imbalance in body fluids. It produces large amounts of urine, polyuria, and makes the person very, very thirsty, polydipsia. And the hormone that's involved is the antidiuretic hormone, ADH, also known as arginine vasopressin. And ADH helps regulate the amount of water the kidneys reabsorb from the distal convoluted tubules as they filter waste and excess water from the blood. Now, ADH is made in the hypothalamus and it's stored in the posterior pituitary gland. Conditions that cause deficiency of ADH or block the effect of ADH will result in polyuria, massive amounts of urine production. What are some of the types of diabetes insipidus? The most common is central diabetes insipidus, which relates to the problem being centrally located either in the pituitary gland or the hypothalamus. And this affects production, storage and release of antidiuretic hormone. Then you've got less common conditions, nephrogenic, must be the kidney, diabetes insipidus, due to a defect which is genetic in the nephron. Or it can occur as a result of chronic renal failure, certain medications that make it unable for ADH to respond effectively. Then you've got pregnancy, gestational diabetes insipidus, which is very rare, and here it's when an enzyme made by the placenta destroys maternal ADH. Then you've got another condition called primary polydipsia, which basically means, primary usually means not aware of or don't know. And this essentially causes a dysfunction of the thirst regulating mechanism in the hypothalamus, and the person involved becomes very, very, very thirsty. What are some of the clinical manifestations of diabetes insipidus? Well, being extremely thirsty, producing huge amounts of urine, frequently needing to get up during the night, and preferring very, very, very cold drinks. Now, if it's severe, patients can produce more than 20 litres of urine a day, remembering that a healthy adult with normal intake produces about 1 to 2 litres per day. Complications associated with diabetes insipidus are dehydration, electrolyte imbalance, weakness, nausea, vomiting, loss of appetite, muscle cramps, confusion. And I guess in the most extreme situation, they could go into hypovolemic shock as a result of severe dehydration. Diagnostics, history and physical assessment are always important. Other things could include what is called a water deprivation test, where you stop drinking fluid for several hours, and weight, urine output, and specific gravity of urine and blood are monitored. Or they can do a laboratory investigation that determines the serum levels of ADH. CT scan, MRI, essentially is to determine whether there's any issues with the pituitary gland or the hypothalamus. And genetic screening can be done as well. What's some of the management for diabetes insipidus? Well, for central diabetes insipidus, if it's mild, you just need to increase your daily water intake. Or if it's related to a tumour located in the hypothalamus, pituitary gland, then surgical removal or chemotherapy or radiation therapy may be indicated. Typically, it's treated with synthetic antidiuretic hormone, also known as DDAVP, or desmopressin, arginine vasopressin. If it's nephrogenic, related to the kidney, a low salt diet to reduce the amount of urine in the kidneys, drink enough water to avoid dehydration, and other medications such as hydrochlorothiazide, which actually is a diuretic, which they don't understand, but this can have an effect and decrease the amount of urine being produced, even though it's a diuretic. Then you've got gestational diabetes insipidus during the pregnancy, just giving now synthetic antidiuretic hormone until the child is delivered and then reviewed. For primary polydipsia, there's no specific treatment other than increasing the fluid intake and possibly getting support. The nursing care plan for diabetes insipidus is fairly straightforward. Monitor fluid balance, daily weight, and how thirsty the person is. Labs can include serum and urine osmolality, serum and urine sodium levels, serum potassium. Administer the prescribed medications such as chlorpropamide or vasopressin. Provide safe access to the bathroom if they're older to prevent any form of injury and decrease the risk of falls. All really lifestyle modification, palliative. Assess skin integrity, apply skin barriers as needed, because polyuria may lead to bouts of incontinence and increase the risk of skin breakdown, especially in the elderly. Now let's look at a contradictory syndrome. the syndrome of inappropriate antidiuretic hormone. Now, syndrome of inappropriate antidiuretic hormone, or SIADH, is also known as ectopic ADH secretion. And this occurs when ADH, also known as vasopressin, as mentioned previously, is produced in excess, which makes it difficult for the kidney to excrete excess water. This can result in a relative hyponatremia due to excess water retention, and hyponatremia is the major complication of SIADH, and it's responsible for many of the clinical manifestations associated with it. Early signs can be cramping, nausea, vomiting, and in severe cases, confusion, seizures, and coma. The treatment basically begins with fluid restrictions to prevent overloading of the circulation. However, other treatment will depend on what's caused it. What are some of the causes, the etiology? And there are numerous triggers, such as brain infections, which could relate to encephalitis, meningitis, cerebral hemorrhage, which is stroke, any form of head trauma, which could cause cerebral edema, hydrocephalus. Some of the rare autoimmune disorders, such as Guillain-Barré syndrome, multiple sclerosis, even HIV/AIDS. Cancers, lung infections, and medications may also cause this to happen, and other comorbidities that relate to respiratory disorders such as asthma, cystic fibrosis, sarcoidosis could be involved, and certainly genetics and hereditary factors. What are some of the clinical manifestations? Well, nausea, vomiting, cramps, tremors, depression, memory impairment, irritability, personality changes, combativeness, confusion, hallucinations, seizures, stupor, and coma. And most definitely here, oliguria. What are some of the assessment and diagnostics? Well, again, history and physical assessment are most important. Blood, so you're looking at routine investigations such as serum sodium, potassium, osmolality, and there is actually an antidiuretic hormone test that can be done. Urine will be assessed for sodium, potassium, and osmolality as well. The management, well, most commonly it's going to be palliative, fluid and water restriction, and if chronic, this may have to be permanent. Surgical removal if there's a tumour that's producing too much ADH, pituitary or hypothalamus, and certainly diuretics such as furosemide. There are medications such as meclocycline, which acts on the renal collecting tubules to diminish their responsiveness to ADH, a bit like a blocker, an ADH blocker. Okay, now let's review diabetic ketoacidosis, which is typically a complication associated with diabetes mellitus, type 1. Now, diabetic ketoacidosis is a serious complication of diabetes mellitus, type 1 in most cases, that occurs when the body produces high levels of ketones. Ketones are acids. And this occurs when the pancreas can't produce enough insulin, diabetes mellitus. Without enough insulin, glucose can't enter the cells, which results in hyperglycemia. And as a consequence of that, the body starts to break down fat stores for energy, which produces ketone acids, which increase in the bloodstream and eventually lead to a metabolic acidosis associated with diabetic ketoacidosis. Now, what's the etiology? Typically, diabetic ketoacidosis can be idiopathic, which is unknown. But most commonly, it's associated with newly diagnosed cases, type 1 diabetes mellitus, which is the most common, or non-compliance with medications. So they've been missed dose or inadequate doses or using expired insulin. Or it can be anything that increases stress in the body, and most commonly this may be an infection, commonly here a urinary tract infection in females. But again, it can be associated with any physical or emotional trauma, such as a heart attack, a stroke, pancreatitis, pregnancy, alcohol or drug abuse, any type of trauma, whether it be psychological or physical, and also the use of corticosteroids. Now, when it comes to the pathophysiology, basically, it's about an insulin deficiency. What are some of the clinical manifestations? Thirst, polyuria, nausea, vomiting, abdominal pain, weakness or fatigue, hyperventilation and tachypnea, often referred to as Kushmal's respirations. You can have a fruity, scented, acetone-type breath because of the ketone acids. Confusion, hypoglycemia, ketonuria, glycosuria. So what are some of the complications or adverse effects related to diabetic ketoacidosis? The most common complication of diabetic ketoacidosis are related to fluid, electrolytes and insulin replacement. So therefore, insulin therapy given too quickly can cause hypoglycemia. Insulin therapy given too quickly can cause potassium to shift into the cells, causing hypokalemia. It can also, because of the blood glucose level corrected too quickly with insulin, can cause cerebral edema. However, if left untreated, diabetic ketoacidosis can lead to changes in level of consciousness and death. However, the mortality rate is essentially around about 3 to about 10%. So how do you assess it? History, physical examination, laboratory tests. Physical examination reveals often dry mucous membranes, loss of skin turgor, tachycardia, hypotension, Kushmal's respirations, abdominal tenderness and fruity acetone breath. Blood tests that are typically done, serum glucose, which typically has hypoglycemia and a high glucose level, but typically less than 300 milligrams per deciliter. Certainly, serum ketones are elevated, urea and creatinine are elevated. Potassium is typically high, but low during, or may become incredibly low during rehydration and insulin treatment. Arterial blood gases reveal a metabolic acidosis, often associated with respiratory compensation, and urinalysis is always positive for ketones. What's the management? Well, the management involves insulin therapy and certainly electrolyte emplacement, such as potassium, magnesium in particular, and absolutely fluid replacement. So let's review. What are 4 clinical manifestations of hyperthyroidism, often referred to as Graves' disease? These are going to be unintentional weight loss, heat intolerance, tachycardia, and so forth. What is diabetes insipidus? Well, diabetes insipidus is a condition that causes an imbalance in fluids, often producing large amounts of urine, polyuria, greater than 20 litres in a 24-hour period, and the patient will be demonstrating polydipsia. And it's a condition where antidiuretic hormone, which regulates water, is not available. There's a deficiency. And as a consequence of this deficiency, there's polyuria. What's the endocrine disorder known as SIADH, or syndrome of inappropriate antidiuretic hormone? Well, this is a condition when you produce vasopressin in excess. And in opposition to diabetes insipidus, you don't produce urine. You have oliguria, weight gain, low serum osmolality, low sodium because of dilutional with fluid retention. But overall, it depends on the cause. Explain the disorder simply: diabetic ketoacidosis. Well, diabetic ketoacidosis is a condition when there's insulin deficiency, typically related to diabetes mellitus type 1. And as a consequence of that, the body breaks down fats which produce ketone acids. Well, that's the end of this presentation. Thanks again. If you feel this has been of any benefit to you, please recommend them to your colleagues, your friends, and subscribe so that you know when there are other Dr. Manny's Learn shops available. Take care, and God bless you all.